So I'm going to ask our speakers for the session to come up, and we'll have a few minutes for questions. And those of you with questions, if you could go to the microphones. Okay, so I think we'll start over here. And if you could give your name and where you're from to start. Great.
Hi, my name is Lucy Sullivan, and I'm the Executive Director of 1,000 Days. So we are an advocacy organization, and we were born out of evidence, the evidence that was put forward in the Lancet series in 2008 on maternal and child undernutrition. At the time, it was referred to as the -9 to 24-month window, and we actually coined the term 1,000 Days. So I was interested in hearing about sort of the breastfeeding data and what we know about breastfeeding and its effects on potentially preventing obesity and rapid weight gain and other metabolic issues. And Sherry, I was particularly interested in your sort of points about dose. And so when we think about breastfeeding, at least in the context where I come from, sort of looking at the global space and following sort of the WHO recommendations on breastfeeding around exclusivity, exclusive breastfeeding for 6 months. And so I think that I'd be curious to hear from you and Dr. Gilman on sort of that notion of exclusivity and what we know about exclusive breastfeeding versus partial breastfeeding in terms of obesity prevention and metabolic disorder prevention. Thank you.
So this question about exclusivity. Now, it's even more complicated than that because exclusive breastfeeding, when you're actually brought to the breast, affects your microbiome versus expressed breast milk, which doesn't. So also bringing a child directly to your breast versus bottle feeding encourages satiety and recognizing satiety cues. So it sounded like a straightforward question, but of course there are complexities. The question has to do with exclusivity. And I do think that there is good data to say that exclusive breastfeeding for 6 months confers many benefits that are essential. Immune globulin transference, very important, with associations with reductions in cancer and type 1 diabetes later. It doesn't, I believe, after looking at all the data, and the Belarus study is a really interesting one, confer a protective benefit for obesity, but it is conferring a protective benefit in all of these other ways, including neurodevelopment. And then just one other word is that women who are using, and in our clinic, we have many Latinos, so las dos cosas, so they do both things. They breastfeed and then they bottle feed. What we see is that they overfeed because they're doing both things. And they're having a harder time distinguishing satiety and hunger cues, and that needs to be assessed.
Yeah, thanks for that question. Just to add to what Sherry said, in the developing world, it seems as though 6 months of exclusive breastfeeding is a very good recommendation. In the developed world, there might be some moderation of that to think about 4 to 6 months. In our study, the optimal time to introduce solid foods for obesity prevention is 4 to 6 months, and there's also emerging data from allergy literature suggesting that that might be the optimal time in westernized societies. Sherry also brings up the fact that in terms of infant feeding, it seems that we need to move beyond just breast versus bottle or breast versus formula and talk about the different ways that people feed. And there's so many different complex ways of feeding. And I think the right thing is talking about how to feed the baby and other behaviors as well that optimize trajectories of growth, which optimize metabolic function later.
We'll try over here.
Sure. Andrea Baccarelli from the Harvard School of Public Health. I was very stimulated by hearing again from Dr. Stein the evidence showing that the effects of malnutrition and famine are more pronounced in female babies. Especially because last time I traveled here at the National Academy of Science, I was part of a committee entrusted to review the evidence on endocrine disrupting chemicals. And endocrine disrupting chemicals many times have the same effect, more effect in females as opposed to males. And I'm wondering whether the susceptibility window hypothesis is enough, and doesn't seem to be enough for endocrine disrupting chemicals, and especially how epigenetics could help to disentangle this mechanism. And if I'm not wrong, Rob Waterland's data on the agouti seems to be transmitted more through the female lineage, or was the female lineage? Yeah. Okay, it depends, okay?
I'm going to, yeah, it depends is always a good answer to just about any question. I would remind you that the differential susceptibility or the differential manifestation of exposures that we see in the 2 Dutch studies that are based on very small numbers in a select population, right? To remind you that at the time of the Second World War, roughly 2/3 to 3/4 of all Dutch babies were delivered at home. And the 2 series that have both men and women are hospital-based prospective follow-up studies. So they are a select group, selected to be relatively low risk, but they are selected. So I would not build a very large edifice on 50 women in one study versus 50 men in that study versus, so, you know, yes, it depends. Yes, there is a signal. Is it a strong signal? I don't know, right? So kind of you know, I hope we never have famines like that to replicate these studies.
Kevin Grove, Oregon. I'm going to challenge Matt, or maybe clarification from Matt on his animal research experiments, because it sounded like you were indicating, I mean, part of the challenges in academic science is there's no real consensus about what the appropriate animal model should be. And I disagree that there should be more of a consensus. And in fact, I think there should be greater variability in the study designs. What needs to be done, which I fully agree with you, is they need to be better powered, they need to be more complete, and they need to explain more about the relevance to human health. Because I think that's the component that's missing, because there's not a human or an experimental design that fits every human cohort condition. And while every animal model, there's no great model for humans, including humans. And if you look at phase 1 trials versus phase 2 trials, they're not very predictive of what happens in phase 3 outpatient trials. But I think what is really missing, which I've seen here this morning, is really the follow-up analysis by an independent party that says, let's look at the studies that have been done or well done, and then look at where their variability and the differences components. Because I think if we can find out why this model here found something that was relevant to humans and this model here didn't predict that, and this model did want this part, then we can actually have an analysis where we can extrapolate what really is relevant to humans, which is what we would all hope to do. But I would argue that we still need to have a lot of variability in the study designs. We need isocaloric, hypocaloric, hypercaloric. We need all of those things to fully understand the whole population.
All I can say is I'm glad I raised the hackles of some animal researcher in the audience. Thank you for the comment.
John Kral, SUNY Downstate in the middle of Brooklyn. First, I want to thank the 4 speakers. Those were marvelous presentations. Dr. Stein, based on a rather gruesome fact demonstrated by Van Italy and others some years ago, looking at the survival of the Irish protesters in prison who went on and fasted to death, isn't it possible that the confounder, and it was so refreshing always to have humility from epidemiologists, thank you for that, isn't it possible that the reason for the amenorrhea and the ones who actually conceived during these awful famines is simply that they had greater body fat to begin with?
Absolutely, but we don't know that. What we do know is that among those who, right, because we have, you know, we haven't got national survey data periodically during the war. Okay. What we do, my assumption would be, right, that because the ability to menstruate is physiologically regulated, some of that is energy balance, some of that might be stress. Those two things were both affected during the famine. There was also, there was kind of, behavioral kind of reasons why women didn't conceive during the famine, as well as physiological ones. All of those are there. All of those are selection factors. And therefore, comparisons between conceptions at that period and conceptions at any other period are confounded.
Of course, there are multiple which everybody must agree with, but I think something as simple as the starting point, as far as body composition is concerned, of the women would make a huge difference, because we know of the relationship between menstruation and weight loss and body fat content.
And if there is a genetic component to obesity, right, women who tend to be fatter would tend to have children who are fatter. That would explain that would be the confounding factor, as opposed to the famine exposure per se. Absolutely.
May I make a comment, Dr. Richardson? I'm all for the extraordinary noise blaming moms, and all for lifting forward the male contribution to the problems that we're discussing. But I think there is very clear evidence that females, girls, women, are much more susceptible to the most of the known stressors. So there is a vulnerability there. It's not a belief. I think there's evidence. And Matt, a comment, if I might. Randomized controlled trials, which you call for in animal experimentation, I think Kevin made some great points. They're very different, aren't they, between an animal, which you can really randomize, and between kids, and between adults who have to consent and go through a consent process, where they are so flawed, the randomized controlled trials in adults, because the buy-in is so short, so small, and the confounding factors are just so extraordinary in who is willing to undergo and not willing to undergo a randomization. Certainly not in desperate circumstances, but even to get access to health care. Some people are hostages, beggars aren't choosers.
So I guess so you're right that randomized controlled trials in humans tend not to be generalizable because they are among volunteers. So typically that's true. There's some cases where it's not true. But just anecdote from a sheep researcher in New Zealand is, well, we go up to the hill and we choose the sheep that look the best, and then we involve them in our animal experiments. So even animal experiments are not necessarily generalizable to the source population that we think they are. Kevin, that's a question. I'm not going to tackle that one.
You have
So-
to ask sheep that question.
So we're running a little short on time, so we're going to ask for one more question, and then we'll have a session afterwards that we can follow up.
This is more of a comment and a conceptual idea between Matt and Sherry, and I really thank you for summarizing those practical aspects of what we need to be doing. And from my perspective, when I do the clinical research and the animal research, and I'm involved in epidemiology research, I kind of hearken back to what we're up against. Nobody has talked about the fetus and the placenta. So you're monitoring mom, you're monitoring child, but you're not talking about what's actually developing in utero. So the way I think about this is the way we developed a screen for gestational diabetes was ultrasound. When babies started becoming bigger, and the Frankel hypothesis, which people don't talk about the early exposures to high glucose, that prompted OBGYNs to start having a gestational diabetes screen. And now, where we're at 2015, is that screen is missing most of the big babies. So either the screen is bad or we're not screening for the right thing. It's further complicated by the fact that what's clear now is that you don't have to be big to be fat. So just like you pointed out, the Indian babies who are fatter, they have probably greater risk for metabolic syndrome. So what we really need is a better screen. We need to focus more on, in terms of science, what can we put our hands around that actually will predict adiposity better than just a few millimeters of glucose, which we know matters, but maybe there's some other things either in the metabolome or in the DNA that comes from the placenta. Maybe it's changing, or maybe in terms of the microbiome or something that we can put our fingers on, that if you follow this pathway, this diet, this change, you know, we can count on this having an outcome that is going to be good. Otherwise, we're monitoring gestational weight gain, not even thinking about how big is that fetus growing. Just want to put a plug in for a little bit more science back to where it might be translatable up to humans.
Thank you very much. I want to thank our panel, and I'm going to turn this over now to Isa.